Welcome to the Global Robotic Assisted Surgery Podcast, or GRASP for short. We release weekly podcasts featuring insights from leading surgeons and other surgical professionals. Our host for today is Professor Hitendra Patel, who is a global key opinion leader in robotic assisted surgery, a global key opinion leader in telesurgery, and editor-in-chief of the World Journal of Clinical Oncology. We hope you enjoy the GRASP podcast.
Welcome to the Global Robotic Assisted Surgery Podcast. I'm Professor Hitendra Patel, and welcome to the audience both watching and listening. I'm grateful today that we have an excellent robotic bariatric surgeon, Dr. Sami. Welcome, Dr. Sami.
Thank you very much, sir, for this kind introduction. Thank you very much.
Just before we start and get into the nitty-gritty about robotics, the audience are always keen to know how a surgeon gets from the dream of being a surgeon to actually getting there. And in particular, in your case, how you then went on to become a robotic surgeon and a robotic expert.
Okay, thank you, sir. In fact, for me, it was a difficult journey. If I want to talk about myself a little bit. It was a difficult journey because when I started to think to be a robotic surgeon, it was in 2010. At that time, robotic surgery was not that popular in the Middle East. So I had to search where I have to go. In fact, where I have to be to get a training, from where I have to start. So the starting point is the key point where you have to start. So I can get best training. So at that time, I started to search, in fact, in the whole world, which area is, for me, is easy to go and to get a fellowship for robotic surgery. And initially, I want to be a colorectal surgeon in the same time. So I applied for many countries. One of them was Korea, South Korea, Seoul. So and I have been accepted there in Sebrans Hospital. And I stayed with them. Initially, they accepted me for 2 years. Then I extend another 1 year more to get more training. In fact, I was the first Saudi to go there, South Korea, and it was a little bit for them. It is difficult, but we adapted within 3 months for the living there, to know new cultures. For them to know Arabic people is a little bit difficult. So I started to be robotic from that point. It was hard, and as a first one, you have to work harder to gain more and to get to be fulfilled with your requirement. In fact, I went there. The volume of cases was high, like around 2,000 cases of colorectal cancer have been done per year. Most of them done laparoscopic or robotic or open, depend, but most of them minimal invasive. And I started learning robotic by dry lab initially, and then animal lab, and then I upgraded to human cadaver, and then I started in human being to do some colorectal cases. So this is the first thing when I started robotic surgery there.
So,
I started
just before you carry on. Sorry, when you went to South Korea, I mean, most young doctors who are traveling for fellowship training, if they're going to another country, I mean, what was the language like? I mean, how did you communicate with them?
Yes, basically I communicate in English language.
Right.
Though there is around 5 major hospitals there, they are speaking English, all of them.
Yeah.
And even the reporting in the system, radiology, whether notes or everything is written by English language. And the professors there usually they spend around 1 or 2 years from their fellowship in the past in United States, so they know how to speak English with me. So the communication was not an issue with me there because it was in English.
So I'm just saying, because people get apprehensive about traveling abroad, and I think some of the best places to learn are not necessarily where you live. And so I think that's a great thing you've done. I mean, I went to the Samsung Hospital in South Korea also, where they spoke perfect English. and had a great time with them. Wonderful people, actually. Wonderful. Anyway, so please continue. So you went to South Korea, and then you went into human surgeries, and what happened next?
Then from there, I started to work in robotic, laparoscopic, minimally invasive. I saw the all rare and common cases in colorectal cancer, whether or benign. And then I had to take, after that, 6 months of my training in France in Nantes University Hospital to do fecal incontinence surgery there, because it was not that in the unit where several hospitals are not treating fecal incontinence. It was separate. And I learned also magnetic anal sphincter, sacral nerve stimulations, and all those stuff, and proctology. In fact, also like rectal prolapses, stapler, whatever. And also I did with them exchange knowledge. So I started with them the first cases of robotic colorectal surgery there in France in Nantes University at that time. So they teach me they teach me fecal incontinence with pelvic floor disorders, and then I teach them in the same time robotic. And then I have to spend one in Brussels, Free University there for bariatric surgery. I spent 1 year there also. I worked laparoscopic and some robotic cases there. So this is my whole journey, in fact. Then I came back to my country to start, in fact.
Yeah. Just tell me, when you got back, were you frustrated because it wasn't the same as being in one of these hospitals performing all this work? Or how did you feel about coming back?
Yes, I came back actually enthusiastic. I want to do more cases. I want to apply what I learned, what knowledge I get, what new technology I gain. But in fact, initially I found a resistance from most of the hospitals, especially those they have robotic machine there, but they don't have robotic surgeons. A little bit, they initially they didn't accept me to work there. In fact, so I have to fight, and people they don't know what's the Korean background and why what's this doctor is coming from Korea, from other countries. So a little bit the people they are afraid from me initially, and in fact after I get to Korea here, I have to get two of my friends after me to work there with me as a fellow, and then our country they make a contract with Korea with the 5 major hospitals there for a surgeon doctor to get a fellowship. So it become dedicated, well-known fellowship in our country, and most of the people, the line becomes straight for them. This is the issue.
You have blazed.
Yes.
I mean, that's
So the issue was difficult to teach people to show the people that we are a good surgeon. Okay, we are not a bad. It is not the medical or the development. It's not only in the West. It can be in the East. It can be in the South. It can be everywhere in the world. They are doing good surgeries and good job to help patients. So the most important to learn in a proper way and to be a safe surgeon at the end.
Were there moments where you thought, I'm not going to bother because there was so much resistance, or how did you get through those days?
Those days is better. I feel it's a little bit better. Now I'm joining a hospital. They call me for a robotic Da Vinci to start up with them. And initially we want to, now we are working on starting up with Da Vinci surgery here. Most of the hospitals, governmental, they have Da Vinci. In fact, but position to get recruited there or to get a position there is very difficult. And private hospital now in Saudi Arabia, we started now in 2 private hospitals. They got Da Vinci. In the Middle East, you can find also in Emirates, in Qatar, in Oman. They started also robotic surgery in most of the private hospitals there. They have it in Egypt also at the same time.
We should just say that there are multiple robotic platforms available now around the world. There are at least 8 different systems, and I think they all have their role to play. But just if we just keep you've fought through all the things. Now you're being invited to train other people. They've set up the fellowship program because of your work between your country and South Korea. So that's a great success, isn't it? You've changed the behavior and the minds and the hearts of many people, Dr. Samir, yes?
Yes, of course, I'm sure. And now I'm happy that to see most of fellows when they came back from Korea, they are excellent doctors and working in major centers in Saudi Arabia here. And they are doing good jobs, minimal invasive with a laparoscopic and robotic surgery, and also in open cases. So I think this is a good place to discover in the world.
So let me ask you, with you sending all your fellows and younger doctors to train in robotics, your role now, do you have to be more aware about those operations that require some open surgery? Do people have to call you to help with open surgery now because maybe they're a bit de-skilled because they only learned robotics? What are your thoughts on that?
What I think the people, when they go to choose a center for a fellowship, they have to choose a center with high volume of cases. Why? Because when you get high volume, means you have to see the different approaches. You will see open, you can see laparoscopic, you can see robotic. If you choose only a low volume, maybe you will see only a little minimal invasive cases like laparoscopic or robotic. You will not get adapted to open cases also. So when you get an open, you will stuck sometimes to operate. But in fact, when I go to Korea there, we saw all. We saw open, we saw laparoscopic, we saw robotic, depend on the stage of the disease, on the cancer, on the difficulties, sometimes insurance affecting also the operation. So this is many factors, but for the surgeon, he has to learn all, in fact. But if he cannot catch all, this is definite, but it is not a shame to call for help. Of course, most of us, we do laparoscopic, for example, cholecystectomy. But when it is, they finish maybe fellowships, or maybe some of the doctors, they finish all their careers without doing open cholecystectomy. So it is not a shame to call for help from others, and it's okay to learn the techniques wherever it is. I want to also to point something more. During this my fellowship, I did some courses and training in United States, in Germany also. It is those courses also in also Switzerland. They helped me also in my career. I did some single board cases. I get transanal excision of cancers. I get also robotic cadaveric also in Switzerland. I get proctology, dedicated proctology course in Germany. So I traveled a lot around the world. So to gain more and to make the things all together, like West and East, where we have to go. Yes, exactly.
One of the main issues you're pointing out is that surgery is not just in the operating room. There's lots to do before and after, right? If you want to manage the patient well. And clearly, by traveling, you're seeing so many different things. That's got to be a bonus. So let me ask you, when you were training for robotics, one of the things that has come up before, maybe you could give us your opinion. How do you pick a case? You know, what makes you go, that's a robotic case? I mean, what makes you think that? How do you go about that process?
Okay. Let me first comment about the surgeon is not an operating room. I like this comment because this was the word of my professor. Exactly. During my fellowship, in fact, usually our professor gave us a task to do a research in the same times while we are doing a clinical work. So we have to stay in the hospital until sometimes 12 midnight. After 9 o'clock p.m., we finish procedures and then we have to stay doing our research. Why? Because he said, when you do a paper, means you are keep updating yourself and reading more papers. So he's keeping up our knowledge. So based in OR, he will not give you more cutting. It's based on depends on how progress in your research. So during my stay there, I had to do around 14 papers, most of them in robotic. So I have to work hard in research to get more gain and again cases and OR. So this is means I have to gain knowledge. I have to know how to approach patients. So now we can go to your question. So how can I select my patient in robotic surgery? In fact, as you know, sometimes in my presentations, what I do, I draw a curve, depend on the case, situation, and surgeon skills. So if the case is a low case, or for example, what we call a simple case, and the surgeon has a low uh, skills, this is suitable for him. So, for example, if you can start doing sigmoid cancer or lab or robotic cholecystectomy. This is good for less skillful surgeon. It's okay for him. He will enjoy it. He will do better. But after sometimes your skills is going up, means you have to upgrade your cases. So you cannot stay on also simple case. So this is the curve. It has to go with you up. So once you get more skills, more upgrading. Now we can do in the past, for example, they don't select T4 cancer patient, the cancer that adherent to other organs. But nowadays, if you get more skills and more experience, you can do also T4 cases. So whatever you can do in laparoscopic, you can do it in robotic. It is the same selection, in fact, for me. In the past, Da Vinci, which is the first machine started in the past, it was not suitable for multi-quadrant abdominal surgery. But nowadays, when they change with XI, is okay for multi-quadrant abdominal surgery for total colectomy, for example. So for selection, I can do every case that I can do it in minimal invasive and laparoscopic. It can be done in robotic. This is in summary.
Okay. So when would you not apply robotics to a case?
I will not apply if I'm not sure about my anatomy inside. So I will not go whether robotic or laparoscopic. I have to go open. If the anatomy is difficult anatomy and you are not sure where I will going, so this is the limitations for the surgeon. He cannot proceed there. Emergency, for example, bleedings or something like this. Also, you cannot go there initially. If the patient unstable case, you cannot operate robotic or whether laparoscopic. So you have to be selective. Patient has to be stable, elective. You are going there, and the patient and the anatomy it has to be clear from the beginning. You can do it hemolysis. You can do whatever. But if the organ's anatomy is not very clear for you, you cannot proceed. So here you have to know your limitation and convert to orbit.
So I mean, that's very sensible advice. I mean, essentially, you talked about learning curves before, about in case selection, but also have the bravery to say, no, this is not the right tool to use for this particular procedure. I think that's, would you agree that, these technologies are basically tools, but ultimately, the surgeon's still the surgeon, whatever type of tool they're using. So it's selecting the right tools. So in terms of energy, we had a few people talking about energy. Okay, so I'm talking about different tools as we've had evolution in robotic technologies. So what's your favorite energy device to use in your specialty?
Okay, good. I agree with you. It's a tools. It is an intelligent tool, actually. In the robotic, I can mention it like an intelligent tool because laparoscopic also a tool, but robotic a little bit different. It's an intelligent tool. It can give you reflections. In fact, for energy, my favorite is the scissor.
Yeah.
I use monopolar. Most of my dissection was a monopolar. In bariatric, yes, we use the vessel sealer device because in our country still we didn't get the synchroseal, which is available, I think, in the West. If we get it, it will be better than vessel sealer, which is a little bit their jaws is big in the vessel sealer. This is in bariatric, but however, in most of my cases, I use scissor as a monopolar, and then the second hand you can have standby bipolar as well.
So you're a very skillful surgeon using monopolar. So if we just move it on a bit now, you mentioned bariatric surgery. So in terms of your practice, what percentage of your surgeries are bariatric? All your practice?
To be honest, it's 50%.
It's
bariatric.
Okay.
Yes. Our obesity rate in Saudi Arabia is very high.
Yeah.
So most of cases we can do bariatric is 50%. The other 50, it will be general surgery, including colorectal surgery.
So the one of the things about bariatric patients, as you know, is the Trendelenburg position. So let's call it extreme positioning on the operating table. How do you manage that when you're operating? What are your any tips or tricks you want to share with the listeners and the viewers?
Yes. In fact, let's start by bariatric. Bariatric, usually I use 4 chokers for the patient. One of them is 10 millimeter for the staplers, and the rest is 8 millimeters. I put them in one line, around 20 centimeter from the xiphoid process. In fact, I'm a little bit different from the others. I don't use a Nathan retractor in the gastric area. I use the fourth arm, in fact, which is in my left side. I use it to retract the liver. So this is the fourth arm for liver retractor.
Yeah.
And then my left arm, I hold the stomach high sky up. And my right arm, I use the vessel sealer to open the laser sac and operating like this way. It is exactly the same what we are doing in laparoscopic. We use only 4 boards. In robotic, I use the 4th board. So I utilize the 4th arm there to lift up the liver. If I needed to take the stomach, a fundus, I can use it just I curve it down because it is curved tip grasper. Just I curve it down and I hold the stomach like this. So it is for me it's very easy to use it. And I use the stapler from my left hand, and right hand I use the vessel sealer. So with this I can do, for example, sleeve, weather, or bypass, whatever the case, in the same position. So it will be all in one line.
That's very clever. So thank you. That's a nice little trick. I'm sure a lot of people will be listening to that and trying it. So is there anything, if you had a wish list, okay, Dr. Sami, and so let's say in 5 years' time, you're asking for something now, but to be delivered in 5 years. Is there anything that you think you haven't got now that you'd love to have in a few years' time for your robotic surgery patients and the tools you're using?
Yes. In fact, what I think before, let me tell you something. During when I learned initially, I learned on the SI system.
Yeah.
SI system, there is many disadvantage, and I published a paper also about the disadvantage of the SI system at that time. And then after that, they make the SI system based on what is the disadvantage there. They make it more thin arms, long instrument, can be used in multi-quadrant abdomen. Robotic, as I said, we are thinking it will be more in the future to become more intelligent. Like now, what we get in a stapler. Stapler, for example, in sleeve gastrectomy, when we do in bariatric, we put the stapler there, and the robotic is reading, is this stapler can fit for this thickness of the stomach, or no, I have to change, or it has to make more compression. So the robotic is clever, can make more compression, can buzz, and more compression and can buzz. So it will give you, it will help you actually in figuring what you are doing there. In future time, I think we can develop something more and more intelligent that can give us more and more information and reflecting more information about the case inside. Okay, so what stapler can I use before I open the stapler? How can I measure the thickness? Is there anything to measure before I put a stapler? Before I open the stapler, in fact, because if it's opened, means it is used and you lost the money there. So this is one thing. The second thing, development of the vessel sealer device. I think in the world it's still in the beginning. Vessel sealer that we currently have is not that suitable for all cases that the surgeons they can use. Although there is still harmonic robotic, but still it is not endorsed. Maybe in the future it will become endorsed harmonic, which is good to have ultrasonic. and versus visual sealing only. And in colorectal, usually in laparoscopic, I use ultrasonic devices. I learned also, I trained in SP system. SP system, and we get it in Korea a few years ago, and I have been there. I go there again. I get a training on the SP single port system, so where you can do this procedure in just one opening there, 2.5 centimeter. You just put your instrument there and it can work, and it went success there. So I think the future is coming for robotic. Each time they develop something different. However, the machines still, we think, is big, as any machine started in the world, and then I think it will become smaller and smaller.
Yeah.
So, what in summary, machine size, visual sealer, and interesting harmonic, if we can get, and more intelligence about the knowledge that we can get it from the robotic to ourselves.
I can see a new career for you in developing these things. That'll be your next role, right? No doubt. Because those are exactly the sort of things where, more intelligence, putting a brain on the robot, great idea. Better energy devices, great idea. I think all these things are happening with more competition. So I think it's coming.
Yes.
I agree with you. I agree. Well, listen, before we finish, there's just I got one more thing to ask you. You told me about yourself and your career, but how about you as the man? What do you like to do to relax? Do you play sport? Do you like to listen to music? What are your passions?
Okay, it's more difficult question on that. Surgeon life is very difficult and very hard,
Yeah.
If we can give the time for our family, I think this is the best. I think for me, if I want to relax, I will sit with my family. This is the first thing to relax.
Well,
my life is a little bit, stressful. We are a surgeon. We get to our thing to make us happy is when to operate. In fact, I like operations because operation is not something just to do for a human. It's an art. In fact, cutting in robotic is something we call it art.
Yeah.
It is like painting or singing or whatever. It is an art. Yeah. If you master this art, you will love it. So it will become your life. The other side, sometimes I do sport. Yes, I do go gym and something like this. But most of the time, I have to sit also with my family and talk to my children, give them some time, make them happy. This will feel me and happy and relaxed more. This is something important. If you give me 5 minutes just to comment about colorectal procedures in quick
yes,
1 minute.
Of course.
Yes. In colorectal is a little bit different than from other procedures in the body and robotic, especially because we call it multi-quadrant surgery. In prosthetic, you are dealing with one area, in bariatric, one area, in cardiac surgery, one area, thyroid, one area. However, the colorectal surgery is you are doing from up in the chest down to the pelvis is a little bit difficult. So surgeons here, just what I can tell them, you have to think about your port position, where the specimen can be extracted, and how can you do the procedure? What's your approach? Visual sealer, that device you have to use. In fact, it is not an easy task. You have to decide intracorporeal anastomosis versus extracorporeal anastomosis. Okay, this is all you have to get and learn about it. With time, we are advancing. We are doing intracorporeal anastomosis to make our incision smaller, to make it away from the whole body down, like thin steel or something that cannot be seen hidden. I think the surgeon must think more broad, out of the box, rather than just when he will do something inside. Try to utilize the whole robot, utilize your fourth arm, how to use it, utilize, for example, ICG, and Duchenne and Green to know about your anastomosis status, about the visuals there. So I utilize the robotic stapler, which is available now. So all this, you can utilize it to get comfortable with robotic system. In fact, this is just a little comment for colorectal, because colorectal most of the time where we need an assistant in laparoscopy, we need at least 2 assistants. While if you do it robotic, you need only 1 assistant. So this is also reducing human power and cost for you.
There are. I mean, you've said so many things in there. We mentioned ICG.
This is my comment.
we mentioned ICG yesterday with the liver surgeons using it for partial hepatectomy, the urologists for partial nephrectomy, colorectal surgeons for anastomotic integrity. So yeah, I think the ICG guys are getting a good. It's a one size fits all. But listen, Dr. Sami, absolute pleasure to speak to you, and it was an absolute delight. And I just wanted to say, I wanted to thank you and say, Dr. Sami, the artist, has a nice ring to it. So, when you finish surgery, we'll maybe we should both start painting, perhaps. But who knows? But anyway, listen, thank you so much, and it's an absolute pleasure. This is the Global Robotic Assisted Surgery podcast. I hope you enjoyed our latest edition. Thank you.
Thank you for listening to the Global Robotic Assisted Surgery podcast, or GRASP for short. Please subscribe to be updated with all of our new podcasts coming out. If you would like to learn more about robotic assisted surgery, please go to www.roboticsurgerypodcast.com.